Here to talk about one of my passion areas, which is where mental health and primary care overlap. How many of you are familiar with mental health supports being integrated into primary care? Can you raise your hand? People have seen that model. Maybe there's a therapist people see there, or primary care doctors might work with somebody on starting clients on mental health medications. I'm going to talk about a different type of integrated care that's really special that we get to do here at LifeWorks Northwest. So we'll focus most of our talk on that. And as Karen shared, I not only, nowadays I practice mostly as a child and adult psychiatrist, but I get to bring this lens of having been trained and practiced as a primary care provider for 5 years as a pediatrician during training. So I really like being able to apply that mindset to this work. And it will definitely inform my talk today. We're going to start by talking through 3 client examples. These are heavily informed by patients I have seen during my time in the 5-ish plus years of working and providing care here at LifeWorks. Some facts have been changed just to protect people's identity, and they're kind of an accumulation of multiple cases brought together. But we're going to talk through those cases. We're going to talk a little bit about what the problems are, what the solutions are, and then we're going to wrap up by revisiting these clients and talking about how we made this system work for them. So yeah, that's our agenda for today. We'll get started. Our first client is named Susie. She's a 49-year-old female. She's in high acuity services for SPMI clients, which stands for serious persistent mental illness, meaning someone has a chronic, lifelong mental illness that they're getting support. Here at LifeWorks, she has been diagnosed with schizoaffective disorder, bipolar type. I realized I did a quick looking around the room, so if there's any term that you're like, please help me understand that, both on the medical side or the mental health side, please raise your hand at any time and I'd be happy to explain that. Susie suffers from chronic kidney disease and she requires hemodialysis 3 times a week as an ongoing treatment for that. She currently is not on any psychiatric medications. She experiences frequent ER visits and is often hospitalized due to complications related to her kidney disease and missing dialysis, often with critically abnormal labs. Any questions about that before I move on? Okay. All right, Nina is a 65-year-old female who is also in high acuity services for SPMI. She's been diagnosed with schizophrenia. She's experiencing an unexplained 20-pound weight loss over the last few months. Unexplained meaning is not an intentional weight loss, is currently on 1 long-acting injectable. Are people familiar with what long-acting injectables are? Great. Long-acting injectables are antipsychotic medications that are given in the form of injection and can last anywhere from 2 weeks to now we have something called Hafira that can last for 6 months. So a client with schizophrenia could get 2 injections a year and be covered and have therapeutic doses of antipsychotic in their body that entire time.
So what does it do? I mean, what's her reaction to having that?
Yeah.
No more episodes?
So it's going to treat the symptoms of schizophrenia that include positive symptoms, which include things like delusions, hallucinations, so kind of an addition of experiences to what a person without schizophrenia might experience, and also some negative symptoms, meaning sometimes lack of interest to engage in things, so it can really help with both of those symptoms, all the core symptoms of schizophrenia. Okay, great question. We're going to move on along. Donna is a 65-year-old female who's also enrolled in intensive services, who has been diagnosed with schizophrenia and PTSD. She reports frustration related to chronic pain and weight gain. She is receiving 3 oral antipsychotics, so she's on 3 different oral medications for schizophrenia, and she's still reporting a significant amount of mental health symptoms that are impairing her functioning. Any questions about that before we move on? Okay. All right, so defining a little bit of the challenge that we are up against. So clients who have an SPMI diagnosis experience a loss of life compared to age-matched peers who don't have that diagnosis. So overall, that's around an average of 15 years. For bipolar disorder, it's slightly less. For schizophrenia, it's slightly more. And then when we combine that with co-occurring substance use disorder, that can be up to 20 years of life lost related to having that diagnosis. This is something that I learned about in residency. It's very unfair. It's a clear health disparity in our system, a significant one. And despite being aware of this, it's been a challenge. The data really looks pretty similar and consistent over the years, that while we notice this, we haven't had the right tools to effectively reduce it. Do people want to guess what the leading cause of death is? It's on the slide. So, but do people want to guess what the leading cause of death is? So we'll talk about medical causes, but that is would be a contributor for sure, a risk factor. Yeah, so that's what people think, right? They think, okay, maybe accidents, suicide, overdose, but that's actually not true. Yeah.
Metabolic disorders?
Okay, yeah. Well, I'll give it away. The number one cause is heart disease, which is just like the rest of Americans, right? It's very reflective. When we look at this data, while there are representations in the data for people who do die from suicide, from accidents, from substance use, from overdose, we also see that the major things that end life early are the same things that end life early for everyone, the same major causes of death. So cardiovascular disease is the number one for people with and without an SPMI, but is more significant and earlier in folks with an SPMI disorder. And there are also additional diseases that are overrepresented, but still impact the general population. Things like respiratory disease, and these are multifactorial, so they have a lot of contributors. Infectious diseases, endocrine diseases like diabetes and metabolic disease would be in there. Liver disease, so again, while it looks similar to some of the major causes of death of the general population, just happening at an earlier age. These health disparities are significant. They're a public health emergency. I think many people in the mental health field have felt that way for a very long time, and yet it's been challenging to think again about the right intervention that can help reduce these disparities, even though we all know they're important. So, and I'll say we have an expert at CCBHC here today, so feel free to ask questions. She might help us out a little bit. CCBHC stands for Certified Community Behavioral Health Center. Among the several principles that are part of this model, which include many great things, right? Access to both substance use treatment, mental health treatment, 24/7 crisis response, and just being aimed at improving the quality of care and making it accessible for those who can't afford to pay, which is part of the model. So there are many, many great things about it. Another incredibly important part of this work is partnering around primary care interventions and screening for our clients. So that's a thing that I got to play a major role in as my role as medical director, which I thought was really interesting. And we'll talk a little bit about what we decided to focus on a little bit later. CCBHCs both increase the number of clients that are served, they decrease emergency room use for those clients, and improve quality outcomes. There's a number of quality measures that we track as a team and the state. All right. So a part of this work is our integrated services and what that looks like. Some people maybe think when they think about community mental health, they think about a therapist, they might think about a psychiatrist or a psychiatric nurse practitioner, but we have a big old team here that does a lot of things and works together to be really effective. So we have case managers who also support our clients. We have a number of other roles, but I just tried to decide to highlight. And sometimes, for instance, those folks might even go with our clients who have a really hard time getting to appointments or attending medical appointments, have a lot of anxiety around that. We have therapists who are providing evidence-based therapy interventions and can be partners in some of this work. We have registered nurses who help give injections and can participate in helping us screen and monitor our clients for chronic medical illnesses. We have care coordinators that help clients transition between different services get in to see our psychiatrists and coordinate between people who practice outside of our clinic. So can be a source of connection, making sure people get referred to primary care, making sure that we're talking with them as we provide ongoing care to our clients in a way that's effective, because medical providers tend to be busy and hard to get a hold of. So, and then, as I mentioned, we have psychiatric providers who prescribe medications, among other things that they do here. And we'll talk about some of the specialized treatment that they can provide in the mental health setting here. And we have partnerships with primary care providers, and this allows us to have, when you have an identified partner that you work closely with, it allows you to build some pathways where you can communicate together much more easily. You might have access to their charts and their notes and vice versa, so we can all be on the same page about how chronic medical illness, their medications, and their mental health treatment in general are coming together. Any questions about that before I move on? Okay. All right, so at LifeWorks, we have a tiered approach, and the more significant the needs, the more involvement we might have from our team-based model. In general, for all of our clients, we're aiming to meet with them, see if they have a primary care doctor. If not, help make sure they get connected to a primary care doctor. And then we also do social determinant of health screening, so looking at an assessment of what needs they have and how that's impacting their overall health. And also we do some targeted screening that specifically looks at IV drug use related infections, including hepatitis and HIV. That was part of what our CCBHC model in Oregon asked us to focus on. And also when you think about hopefully all of our clients having primary care, they're quite good at looking at some of the other reasons that people might have HIV and hepatitis, like having workflows that already look at screening for sexually transmitted infections based on their age and several other risk factors. So anyways, this is a nice pairing. That's one of those things that primary care doesn't have an excellent carved out workflow, in a way that we add something special to our population. All right, the second tier might involve seeing an external primary care provider. Most of our clients hopefully are coming in or are established with one, and then having some care coordination that would happen between our nurses and their primary care team. Like for instance, if you think a client who has depression and maybe the depression gets in the way of them monitoring their diabetes and checking their blood sugar and taking their medicines, what a great world that one of our nurses might be able to talk with that primary care provider. And then, right, we have a lot of therapists who are extremely skilled, I'd say, and psychiatrists, mental health providers who are extremely skilled at thinking about behavior change and how to help folks make that. And so how do we bring that together in the neat package? And I think the thing that sounds scary about this sometimes, but is actually really cool, is people think that they're like, how am I gonna impact my client's diabetes if I'm a therapist? But actually, right, it's about letting the primary care doctor help outline what should be happening, and then bringing your expertise around how do we help a client make that behavior change, which we're actually really good at. So instead of feeling like you're out of your scope, it actually just feels really like supported and like everybody's working together as a team, but able to offer their expertise. And then the next level up from that would be for our most, our clients who have the most needs, would be seeing a psychiatric provider at LifeWorks Northwest and seeing one of our primary care partners that we are in more close communication with. And we, like for instance, when we had our primary care provider that I was working with closely, sometimes we could do joint appointments with a family or a client to talk about the overlap of how the psychiatric medication was impacting their metabolic disease, but what primary care could also do to help with that. So it can be a really great model to just have a lot of, a really strong team. Yeah.
That coordination, is the patient involved in the conversation, or is it a conversation between the caregivers, so to speak?
Yeah, that's a great question. Usually, I would say there's a tiered approach. Most of the time, it's happening between the providers and the care teams, there are times that we include family members or clients as well. Yeah. And so it kind of just depends what the need is and what the best way to address it is.
Do most primary care doctors are receptive to combining and using together?
Yes, they love it. Again, and as someone who's worked with multiple primary care providers over the years, I think they worry that they'll be like responsible for managing all the psychiatric medications. They'll be responsible for knowing which labs to order or even ordering the medications. But that's actually none of that's the case, right? Like it allows them to focus on physical health needs and let a psychiatric specialist take over that piece. And right, like even when we're talking about monitoring labs for a client, I'll make recommendations. This, and this lab should be checked every 6 months. We might want to check it earlier if. So it's really a bringing together of our expertise in a really effective way. That's a great question.
Does LifeWorks contact the primary care? Do you have any primary care that call on LifeWorks?
Yes, I would say both ways. It happens both ways. Yeah. Yeah, and again, we have, in Washington County at Beaverton, we have a dedicated primary care provider who sees our most acute clients. So it's really one person that, like, when I was doing more direct clinical work for adults, we met weekly. I read every single note that she put in as a primary care note for our clients. Those are reserved for some of our folks who have the most significant needs, that level of wraparound, but it's an excellent support. Yeah, great questions. Anything else before I move on? Okay, nice. All right. So we'll keep going on solutions and what that looks like. Part of what that looks like is antipsychotic medications for our clients with psychotic disorders. And as you can see, is anybody familiar with clozapine? Is that a medication that rings a bell? Okay. Clozapine is an antipsychotic that has the most evidence base for treatment refractory schizophrenia, meaning someone's at least tried 2 antipsychotic medications and hasn't had a successful treatment response, which is usually not a complete reduction and elimination of their symptoms, but does mean an increase in functioning and overall feeling better. So clozapine has a lot of evidence for helping folks with treatment refractory schizophrenia. So this is a risk reduction in all-cause mortality, showing that people who are on clozapine actually live longer. They have a reduced risk of death. And long-acting injectables, as I mentioned before, are the other intervention that has evidence for helping folks. So part of the important thing we do is identify the folks who need these treatments and help provide them in an ongoing way. We have psychiatrists who will prescribe them. We have nurses who will often give the injections, and clozapine involves quite a bit of specialty psychiatry work. We monitor white blood cell count because there's a serious risk of a rare outcome that they'll have a dip in their white blood cell count that help fight infection. So it's a really powerful intervention, but one that definitely warrants our specialty care. Yes? Mm-hmm.
Is that like partly because like you don't have to be as like monitored on it? Like you get it and it's 6 months before you can go 6 months before you can see a doctor, and in theory, like is there something about the level of care they're getting between these, or like why is that different? So
yeah, so these are going to be different populations at baseline. Part of it is folks on clozapine often have a more significant amount of impairment from schizophrenia. And so by the time the impact can be great, but there are also significant risks, as I talked about, of low white blood cell count. So we're usually opting to do that after we've tried multiple other interventions and they've been unsuccessful. So this really looks at the data for those more vulnerable populations. Does that answer your question? So they're not necessarily the same population that's going to have the same risk reduction. Long-acting injectables, on the other hand, right, are something that actually have great evidence from like first episode psychosis, and in particular, Yeah, it can be a great intervention right from the beginning, right? Part of the magic of those is that they really help with adherence, right? If you can think about. Yeah, yes. You got it. You got it. And sometimes like we don't always make it easy for our clients. Some medications, like people are on regimens that are 3 or 4 times a day. That would be extremely challenging for any of us to adhere to. So it can just be a great option.
Is there any difference in how long one's been available versus the other? Or are they about the same? Like, are they comparative?
That's a great question about when they continue to introduce new long-acting injectables, including just a couple of years ago. They made Hafyera, which lasts for 6 months. So I would say overall, I would guess that the long-acting injectables are newer than clozapine.
Runway. Is clozapine not available in a long-acting?
It is not. It is not. And it requires a significant amount of commitment from clients. The standard of care is weekly blood draws for the first 6 months, every 2 weeks for the next 6 months, and then monthly thereafter. We used to have a REMS program, which is a risk modification program that basically if you didn't get your labs, you couldn't even get your medications filled. So it's again, a medication with a lot of benefits, but also a lot of risks.
I know years ago we were known to be one of the kind of earlier adopters of long-acting. I was just curious, do you feel like we've stayed in that sort of LifeWorks as?
Absolutely, I'd say we're ahead. Yeah. Well, you gotta take it where you can, if it's honest. I think some mental health settings, they don't always have nurses, and also a lot of psychiatrists and psychiatric nurse practitioners aren't trained as much in procedures as maybe like primary care or other physicians are. So that can be a major hurdle. Like even if a psychiatrist will order it, they'll often send it to a pharmacy, then they'll have the family go pick it up, or the patient, from the pharmacy, then drop it off at primary care, then schedule an appointment. So it's like a 5-step process. And we're really lucky that we have all the things in-house to make this really seamless. And yeah, I train all of our child psychiatry fellows to do this too, because it's actually super easy and there's no reason that we shouldn't be using it more often. They'll do too, and they'll be ready to go.
Are these expensive treatments?
That's a good question. If we compared it to the price of, I'll have to get back to you about that. I don't know it off the top of my head, but I think if we compared it up.
But, is that a problem? Someone needs it, but they don't have any coverage to get it?
Generally, no. Clozapine is no longer, it is now a generic medication, so it is not expensive. And long-acting injectables, while they have a higher price per unit, if you compared 6 months of pills that are sometimes multiple times a day by that, I will say I've never filled out a prior authorization for long-acting injectables. They are on OHP's health plan. I've never had an issue getting my clients one of them. That can be a little bit different, I think, for private insurance, but we primarily treat.
Is the long-acting injectables, are they generic yet, or are they still?
They are all, I think, well, no, like there's some older ones like Haldol, Decanaway that are older.
I just thinking of HR1 impacts and who lose coverage, scholarships, pharmaceutical scholarships for those is going to be a challenge.
Good questions. I'll have to do some research.
Yes.
Yes. Yes.
I'm interested in the business of addiction
Mm-hmm.
and how you separate that out to figure out whether you're best served by using the injections or whether you got to make some sort of a entry for the person into some self-help somewhere or that kind of thing. I hope I'm making some sense.
You are, and this is a complicated issue. We'll get to a little bit later because there are some long-acting injectables and injectable medications for substance use disorder now. So that's part of the picture. And then also there's this question maybe that you're getting at, that people who use substances, sometimes it can look like they have a psychotic illness, and that's a question that you're trying to figure out where their symptoms come from. Yeah, it's a good question. I'll try to get there in my talk. I think I have a slide on it a little bit later. So as you saw on the last slide, clozapine has a large mortality reduction, specifically for folks who've been diagnosed with treatment resistant schizophrenia. Long-acting injectables also are decreasing mortality, again, different population that we're talking about, generally less vulnerable, but by around 20%, and are specifically helpful in first episode psychosis. When possible, in general, when we're prescribing medications, talking about the way it impacts some of the other chronic health conditions our clients are experiencing, you want to use lower risk medications in terms of metabolic side effects ongoing. Sometimes people will need, our most effective tend to be the most heavy metabolic risk medications. So sometimes you can stabilize somebody on one of those medications, but switch them over to something that's lower risk in the long term. So that's an important part of ongoing management that we can provide. And then, of course, you want to be monitoring all of our medications with important things like labs and vital signs, and that gives us a good sense of how the medications we're prescribing are impacting the body and making sure they're safe to continue. All right, another part of this, another solution that I think we have great tools for. We see high rates of tobacco use in the SPMI population, ranging from 50 to 80%. There are several evidence-based FDA-approved treatments for smoking cessation, and I think our mental health teams can play a really large role in helping our clients work towards that, which is an important intervention to decrease cardiovascular risk, just like it is for anybody else. Tobacco use still remains the largest preventable cause of death in the United States overall, so just like that, especially for our population where there's higher rates of smoking, it's going to be significant. So I think right between our abilities, several of these medications, like bupropion is a medication we also use for depression, so it's a medication we're really familiar. These are really simple medications to manage, so our psychiatry team, or in coordination with primary care, could work on both offering pharmacology options, but also the behavioral supports around stopping smoking. And together, that can be a really successful intervention that can decrease cardiovascular risk by up to 50%. So a good opportunity to us to really serve our clients in a meaningful way. Karen introduced ACLM, which is the American College of Lifestyle Medicine. I became board certified in this a couple years ago. You might not know this, maybe you do, but a lot of doctors are not really trained in interventions outside of procedures and medications, but I think we're ignoring a really important part of health. And so I did this, and it might not seem, the 6 pillars, none of them might be that surprising to you, but I also believe it's really important to learn about this from the evidence base and make sure we're recommending things that are going to make a meaningful impact for people. And the cool thing about this is, I think, right, stress management, social connection, substance use, those are already things we're really good at talking about in mental health. And we have an opportunity to bring in even more to serve our clients, talking about sleep and ways to get good sleep, physical health, physical activity interventions, which again significantly can reduce cardiovascular risk, and nutrition, which focuses on a whole food, plant-based eating, right? And it's about getting those good things in your diet: fruits, vegetables, whole grains, beans. So I think our challenge is how we bring this into our service area and use it to help all of our clients. One of the things that can be challenging is making sure we're doing this in a way that's trauma-informed, that's meeting the client where they're at, and that's taking into account their social determinants of health, because what we don't want to do is ignore all those things. I think, right, that in my personal work with clients, I believe absolutely this is an important part of the care we can provide, and they can be successful, but it's about meeting those in the right opportunities and helping them connect with the things that can support these goals. We'll talk a little bit about that later with the client example. All right. Yep, and so my strategy is using all the interventions that we talked about on the last page as the first line, and then basically if that's not successful, we can always think about medications and working with primary care to address metabolic diseases. and support weight loss if that's something that a client is interested in. But we can do this, in partnership, and really bringing it all together can be really successful. And then just to bring in the sleep piece, an important part I think that we can do is rule out medical causes, which include things like obstructive sleep apnea or restless leg. We want to make sure those things aren't getting in the way, and that can be an important part of our medical team. But really the best intervention for insomnia, once those other things have been ruled out, is cognitive behavioral therapy for insomnia. So that's a great thing that we can lend expertise to in the mental health field. That's usually delivered by therapists. So before we can also prescribe sleep medications. That's the next step up. So how do we make that work until our client's feeling better and getting good sleep? All right. And then, any questions? Okay. Yeah.
Because so many of at least the older medications, consumers felt like the weight gain.
Mm-hmm.
Are they using these new, is it GLP-1? I forget them, right?
Yeah.
Is that entering in, and how's that all work?
Yeah, that's a great question. So that is primarily, and there's been other medications before GLP-1s, like we would often use metformin. Some people would use some off-label medications, but metformin has a good amount of evidence for either reversing weight gain or preventing weight gain related to antipsychotics. Some people will start it as they start the antipsychotic if they're using an agent that's higher risk and someone's sensitive to side effects.
Long-acting have weight gain issues?
Most of them do. Most of them do, and the ones that don't are the older antipsychotics, and they have their own challenges, like they have increased risk of motor abnormalities, so. Mm-hmm.
I've heard that the GLP-1s can help, or there's early slants that can help with addiction.
Yeah.
About that? Can you speak to that at all?
I have heard some talks on it. I think it's really interesting. It seems like something that was almost kind of discovered by accident, that people were smoking less or drinking less. So I think it's really exciting. Yeah. Mostly primary care has been managing GLP-1s. I am on a community psychiatry listserv with all the leadership across the Portland area, and mostly that's still happening by coordinating with primary care, because there are some serious risks with GLP-1s. But I think it's a very promising, exciting new area, and I had several of my clients who were started on a GLP-1 in primary care while working with us. So yeah, for some of them it was really helpful, for some it wasn't. So that's why we have all these options off the menu. Okay, let's see where we are. All right, we already talked about a little bit. This works the best when we're a team, and right across their mental health team and their physical health team, we're all kind of given the same messages. I think that definitely an important part of helping our clients achieve good outcomes. And then, as I mentioned before, just making sure we're taking into consideration some of the things that might make this a little bit more challenging, like some of the social determinants of health our clients face, some of the cognitive symptoms they experience that could be related to their SPMI illness. So making sure we're delivering this in a way that's understandable and appropriate. And knowing that their medications play a role in this. So. All right, are you all ready to go back to Susie and our case? We're doing well on time, so that's good. So we'll wrap things up and talk about how this applies to those couple clients that I introduced at the beginning. And I'm going to ask you to put on your hat as though you're a psychiatrist today and see how things turned out for them. So for Susie, you start by building a positive treatment relationship. That's always important, no matter what part of this work we do. It's really important to have a trusting relationship, and that does predict outcomes pretty much across the board. Once she trusts you more, and remember, this was Susie who wasn't on any medication, was supposed to be going to dialysis 3 times a week, but wasn't attending. Would go up to a week and a half without going to a single appointment. Was ending up in the emergency room in the hospital quite a bit. So once you develop a trusting relationship with her, she tells you that she doesn't really have renal disease and that she goes to dialysis because the FBI has agreed to pass her top secret information when she goes there, which you understand, and this is part of something you get training for in psychiatry. you understand that to be part of her mental illness and a delusion. And so you work to try to restart her psychiatric medications, which can work to treat those delusions, as we were talking about earlier. Try to better control her symptoms and hopefully improve her attendance of those dialysis appointments. Unfortunately, that doesn't go so well. She's not super interested in restarting those. You coordinate with her primary care doctor and kidney doctors to share your perspective as her psychiatrist that you do believe that her mental health is impacting her ability to understand her kidney disease, and you understand from them at what point with missing dialysis appointments she might be at risk of harm to herself. When does that become dangerous for Susie? Which is something as a psychiatrist isn't exactly in your wheelhouse, but this is the power of a team. You coordinate with your high acuity team and with the crisis response team, a wonderful service we have here at LifeWorks, to help get her to the hospital when she is at high risk to prevent anything bad from happening to her. You keep working with her on her psychiatric medications, and while she doesn't see a need for them, you recommend that she works with a legal guardian who can help her in the decision-making process around both her mental health medications and decisions around her physical health. And that help keeps her safe. She gets back on psychiatric medications with the support of this legal guardian, and she shows an improvement in her understanding of her kidney issues. She is able to reestablish with a dialysis clinic and is attending 3 times a week and is no longer ending up in the hospital every other week or so. Questions about that?
Yay!
Yeah! It's awesome, right? I think, right? Susie didn't want to be in the hospital over and over again, admitted for several days. She didn't like how terrible she felt. While she had some challenges in understanding that, the support of a guardian who almost acts like, since I do a lot of child psychiatry too, it almost acts like a parent might. It can be a family member, it can be an appointed guardian, so it's just someone to help weigh in on those decisions. And that was really impactful for her, getting back on medications and overall just feeling better and getting to live life outside of the hospital.
I would think finding a legal guardian is sometimes a challenge.
You are not wrong. It's not an easy process. It doesn't happen overnight. And it is a legal process, so it requires going to court. Sometimes there are funds to help with that, sometimes less so. And then a major lack, if any of you want to write in to anybody about it, is we have a lack of appointed guardians, which are basically employed guardians who can help vulnerable folks like this when they don't have a family member who wants to take on that role. So yeah, we could use more of those. It's amazing work, very impactful.
In the team, and I'm assuming, because I know we do this, but you didn't specifically call out like people with lived experience or peers, that we use in the workforce, like that they might be on a special team, part of also some of the outreach or connection.
Absolutely. I focused more on, and we had quite a few team members that I didn't put on here just because of slides and brevity of the talk, but this was a team that had a peer, and I find that to be an invaluable service. I think the connection and the conversations is just very different, I think, from the inherent power dynamic that happens between a physician and a patient. So I very much appreciate the role that peers played, and I think how it helped us connect as a whole team with somebody. Yeah, I'm a big believer in that. I never got to work with a peer till I came to LifeWorks, but I'm a huge fan.
What degree of transparency do you guys have to have around how much teamwork you're engaging in with their other providers?
Mm-hmm.
Or what are people that paranoid?
Yeah, I think that is a great question, and that does come up sometimes. Again, I see this as a really protective, good resource. We do include it in our consents that this is a standard of care, and this is all covered in addition under HIPAA. We like to get releases of information in order to make people aware of this and kind of just reiterate that point that this is our model of care and how we provide care. But sometimes folks do have concerns about it, and we do follow the rules of confidentiality.
Do you things in front of them with their, like, their primary care provider or something, or like how do you, if there are, like, if they do feel like maybe you're starting to get like nervous that people are like working against them, or that you guys are gossiping about them, or like feel insecure about that relationship, is that ever a thing that you guys have to do? Like,
Yeah, and I will say, so I did very highly team-based work. It was just as much of a concern. Most clients, it was not a concern. Most clients are so appreciative of the coordination and how, you know, in a fragmented medical system that's hard to access and hard to get what you need sometimes, it worked seamlessly. People got into primary care quickly. They got their medications covered. So most people, it was not a concern at all. Most people were actually quite appreciative of the model. Rarely that did happen, and people have a right to not participate. Like if they didn't want to see an kind of partnered primary care doctor, then of course they would have that choice to continue with whoever their preferred person is. We have ability certainly to coordinate medical care under HIPAA as a standard. We try to respect that. If it's an unsafe emergency, then we do need to do that for safety, and that's something that we have to tell people. But we do try to outline this so people know what to expect, just because expectations are important for all of us. Most of the time, this is happening behind the scenes, and again, it's happening to a degree based on the needs of the client. But sometimes we meet with people together, and that can be really helpful, especially when there's mixed messaging or concerns, specific concerns. Okay, shall we move along? Let's see what's going on with Nina. I tried to pick cases that kind of range the spectrum of what this work can look like. Nina, you start working with Nina again, you build a positive relationship. That's always 101. You meet with her primary care provider weekly, as I talked about, as I did for many of my clients, and her primary care recommends further testing. This was the client that had 20 pounds of an unexpected weight loss, which is a concerning finding. So you see Nina regularly, you make sure to check in on her physical health symptoms and her weight loss and appetite. You continue talking about that with her and discuss the testing that had been recommended with her primary care doctor. She's generally not a big fan of doctors. She lets you know that. She doesn't like being in the medical setting. But she's also willing to have these conversations with you. She reports she's not interested in testing. You discuss the risks of what it would mean to not pursue that testing. And you check in with your wonderful team that includes multiple types of folks, including a peer, an RN, a therapist. And you learn that Nina has been experiencing dizziness and weakness. She even had a fall a few days before you saw her, and that's part of the reason why she was urgently added to your schedule. She did not want to go to the hospital, talk to her primary care doctor, or go to the ER. You talk with Nina about the fall and her physical health symptoms. She agrees to schedule with her primary care provider later that week. She doesn't want to go to the emergency room. She's very clear about that, and she understands what happens. She remembers the conversations that you had, and she's able to state those back to you. You follow up with Nina's primary care, who's also had these same discussions with Nina, that it is not her wishes to pursue further medical workup. Nina was able to discuss why she made that decision and describes the risks with her primary care doctor as well, showing you all that she understands the decision and that you have very low suspicion it's being impacted by her mental health condition of schizophrenia, which was being treated by a long-acting injectable. You attend a ceremony several months later to honor Nina's life. She did pass away at her own independent apartment. She'd been successful living there for the last couple years, and you know that those were her wishes and you respected those. It's always hard to lose a client, and I debated putting this last line in, but it is a true experience that I've had. And I think now that honoring someone's wishes around death is really important. So I see it as a complicated outcome, but a good outcome. Okay, Donna. Once again, you get to know Donna. You talk about her goals for care. You develop trust and all the essential pieces of establishing a treatment relationship with her. You ask about how she is taking her medication, and you learn that she was prescribed 3 oral antipsychotics, but she's not taking any of them consistently, so they're not working. And her fear about them is that they make her feel tired and that she wants to lose weight, and they've contributed to weight gain. So you talk her through what that could mean and some other options. You discuss switching her over to a long-acting injectable that's very metabolically neutral, meaning it has low risk of weight gain or other metabolic changes. You switch her on over to that. You lower those 2 other oral antipsychotics that she doesn't really need once she's now taking that long-acting injectable consistently. And you talk about, should we pursue a GLP-1 or metformin or a medication like that with her primary care doctor? But Donna decides that she wants to give it a try with lifestyle changes with the team support. You discover that outside of her passion for art, she loves walking, swimming, and weightlifting. And you help her set specific and achievable goals around her physical health activity and incorporate healthy foods. Her whole team cheers her on as she makes these changes over the years. You follow Donna as does her PCP, and she is down to 1 long-acting injectable antipsychotic. She's achieved significant healthy weight loss without needing any medication and is experiencing far fewer mental health symptoms. You work with Donna because her next goal is being out in the community and building more relationships, and you watch as she has the confidence to present at an open mic poetry night, which you think is super cool. Yeah, so that's Donna. Any questions about those 3 cases and how this model applies and looks a little bit different before I wrap up?
I assume you guys have, like, you probably have a lot of clients that, like, regularly end up in, like hospital, like, involuntary, like, situations, right? Like,
Yeah.
is that, like, common within the process of care that, like, you have to, like, step people up into, like, higher levels of care and then back down, and they're, like, is that, like, common with a client throughout, like, that you guys work with, or is that?
I would say it depends. You're talking about to an inpatient or like a residential, like a high level of care, and then back to an outpatient level of care. Yeah, it depends on the population, I would say. For a high acuity SPMI population, likely that's going to happen more often than maybe like an adult outpatient population or even a child and family population. So it kind of depends on the population and where you're getting referrals from. For this caseload that I was talking about, these referrals often come from high ER utilization, inpatient psychiatric hospitalization, or high levels of legal involvement. So that was basically essentially they were coming to us because they did have high levels of engagement and higher level of care. Yeah. Okay, so moving forward, what we do. So just to review kind of like what this talk was mostly about and how we understand the problem. Folks with SPMI have a 10 to 20 year mortality gap. And again, most of that is driven by preventable physical health conditions, estimated up to 2/3. We have a great team-based care model that works here that, that brings a whole team of expertise on how to solve that. And again, can include parts like making sure we're prescribing antipsychotic, metabolic management, including with primary care, smoking cessation, lifestyle interventions. All of those coming together is really where the magic happens. Engagement in primary care and physical health care in general. And where we're going from here. So as I mentioned earlier, our folks who have co-occurring disorders are even the most at risk for years of life loss. So we're really working towards a co-occurring disorder treatment that provides medications and services for both substance use disorders and mental health. We have a significant part of our population who are experiencing both of those at once, and how do we make that really a holistic care instead of having to be fragmented and see multiple people for multiple different things. That's definitely a goal we're working towards in medical services. Continuing to work towards implementing lifestyle interventions across the spectrums of care and our different levels of care to modify risk factors. Continuing to just advance the CCBHC model. I'd love to see them include some other things, like some states they do have a nutritionist, and not only could that, maybe there'd be an on-site cooking class, but also sometimes it can tie you into medically tailored meals and things that are covered by Medicaid that can be great supports for our clients who have more significant needs to allow them to achieve some of these things. So we'll keep working and chugging along on that. And then, seeing how this works, tracking it and studying it. I think I love the CCBHC model. I think it's really exciting. All right, and there are my references. So that ends my talk.
I have a question. So all this push toward data, so thinking of this model, like, do you feel like, I know we're finally getting data, but this whole thing of predicting, like taking some of these, do you see like that's starting to come to practice, like as you look and share data with primary care? Have we gotten, I just feel like we've done a lot to prepare for it, but have we really started to implement at that sort of clinical level,
indicators,
where it kind of can start to lead you, just the data itself?
Yeah, I mean, some of these things we're talking about when we're looking like at all-cause mortality, I mean, those are such big questions that I don't know if the data to support all of it, but I think there's certainly parts of it that I think we have data now that, right?
Just like the partnership with Care Oregon.
Yeah.
I know we keep trying.
One of the neat things medical services has done is, I think it's called point-click care now, it used to be called EDIO, pre-managed, where Care Oregon has risk factors, they assign client the risk factors that we import into our system, and then this team has care pathways based on what they're seeing. So that's
perfect.
that's a little bit closer to like.
At least it's starting to inform.
And part of that was, we've been working on that forever, but CCBHC also added some zhuzh to it, which forced us a little bit more into operationalizing it in a more meaningful way than we had done before. So.
A lot of senior therapists, especially, I was living with a therapist through COVID, and she was always like, we're more caseworker than therapists right now, because she's just like, the need is the issue, How is this, like, working in this model, like, affected that for you guys?
Yeah, so I try to allude to this a little bit in one of my slides, right? I think if you're asking about like some of like the lifestyle interventions, or maybe like, hey, we really want to help get like, you're overdue, you have had a high risk, like 30-year smoking history, we really want to get you in for a lung cancer screening, right? We definitely need to pair that with where folks are at. Again, I have a client that I'll never forget this. He talked about this often. Someone brought him food and he was homeless, and they brought him a bag of uncooked rice and beans. And while those are healthy foods, like he totally couldn't eat them. And for years and years and years, I mean, this happened probably at least 10 years before I met him, he still brought that up as something that deeply upset him. So I think it's about, right, it's about seeing the opportunity, like building on these things. And there's a moment where this is a great thing. And again, like Donna, who I talked about, right, was capable of making incredible changes. She was in a pretty stable living environment. She, right, wasn't in a mental health crisis. These things actually helped her mental health and her physical health and her chronic pain. But I think it's about seeing the right opportunity, right? If someone is coming to you, like, expressing suicide, that's not going to be the moment that I'm like, hey, did you think about like taking a walk today or counting your steps or like eating beans? So it's about, I think, listening to where people are at and finding the opportunities for this.
Do you feel like this model makes that easier? Because it is like, I feel like part of the problem is like, when people need things, they need it then, right? It's like, is it more accessible to you guys because you work in this model, that like those resources are more?
Yeah, finish your, do you have a?
Yeah, just like, I guess it's like, because normally, like, if you're a therapist and you're like, okay, well, they don't have food, or they don't have like healthcare, they don't have whatever, it's like, you have to go find it.
Yes. What I will say about the model is the fact that this is a priority and it's part of the way it's designed and structured. What happens in a system like you're talking about, right, is that somebody does it when they absolutely need to because they're really worried, their client's been admitted to the hospital multiple times, they have these really red flag concerning systems. What happens when you bake in integration, it's part of what you do every day, is that it happens in a routine way outside of more urgent situations. So I do think, yes, this helps you achieve that. It's still about being strategic and knowing, I think, when to focus on what. And I think anytime you're going in and meeting with a client and putting your own agenda in front of theirs, you're just not going to be successful. So if someone's like, listen, Dr. Taylor, I want to talk about this, I need this much change, I'm going to let my agenda go and try to find another time where maybe we could do some of this work. And again, making sure that they want to, right? I mean, they have every right to be like, pass. That's okay.
I am like jumping out of my chair.
Ooh.
Because we have a prevention program and we work with parents. And a lot of times what we see is what you're talking about is where people are trying to do therapy, but they're putting out these fires.
Yeah.
The families are going, homelessness, or they can't, their electricity is turned off. And so there is that support there if they refer to a program like ours, and I assume there are other ones for people who are not parents. But, when you see that that's happening, there is a resource, because especially the man with the rice and beans and he didn't have a way to make it. Well, we go see them every week, and we would be able to say, oh, well, let's figure out how we can do that. I can show you how to do that, or we can, find a place where you can make this food, or let's see if we can figure out other foods that you can get. And so I know that therapists often don't have time to do those nitty-gritty things, and that's what we're there for. If somebody can't, if they're prescribed medication and they want to do it, but they don't know how to use the transportation system, well, that's something we can help with.
Yeah.
Or help them budget so they can afford their medication, or so I feel like we do have those things at LifeWorks.
Oh, absolutely.
Yeah.
And this is.
And so that therapists are working on the things that therapy is for.
And I think there's both this goal, right? I don't know if you work here at LifeWorks for like many years and you don't buy into like, we need to be mindful, we need to be meeting people where they're at, we need to be focusing on what they want to focus on. And like, even if I'm not like, right, it's not my job as a psychiatrist, I'm never going to be like, hey, that doesn't matter, I'm here to talk about your meds. So I think it's both about allowing people to really own their role and focus on that, but also being flexible enough to be like, I get it, your biggest concern today is this like bill and that your water is going to be turned off, like let's pivot, right? So I think probably most of us at LifeWorks are pretty good about doing that.
I'm sure, but it'd be nice if it was fixed before they came and saw you and say, oh,
yes,
tell me what my light bill, so I don't have to talk to you about that.
But you know how life is. You know how life is. And I think I think it's interesting, in other medical settings, since I teach a lot of students and residents, I realize that, in this hospital setting, they're just really far away from that. I think it's one of the things they learn, that of course that stuff matters. And like, we can all be flexible in thinking about how to be a team around that. And because again, it's their treatment, and I feel like making sure their agenda is honored is just really important. Anything else? Thanks, everybody.
Thank